What is the benefit of the perioperative measurement of serum creatinine in the early detection of ureteral obstruction after gynecological surgery? A retrospective analysis. My disclosures. Dear colleagues, the ureter is the enemy of the gynecologist. The incidence of ureteral injury in gynecological interventions is reported to range between 0.4 and 3.0%. Conversely, 75% of all iatrogenic ureteral lesions originate from gynecological operations. Only 1/3 of these injuries are detected at the time of surgery. The other 2/3 of the injuries are verified some days later normally. To speed up the diagnosis, measurement of serum creatinine has been recommended, which may temporarily indicate even a unilateral ureteral injury if a postoperative increase of more than 0.2 mg per deciliter has taken place. We aimed to classify the importance of perioperative measurement of creatinine compared with clinical symptoms in the early detection of ureteral damage. We collected 9 patients with suspicion of postoperative ureteral impairment, under which 6 urogynecological, 2 obstetrical, and 1 oncologic patient were represented. The perioperative analysis of the medical records was about the onset of clinical symptoms, change and time frame of creatinine, sort and time of diagnostic procedures, as well as type and time frame of postoperative interventions. This slide is about surgery and underlying disease. 6 patients underwent an anterior colporrhaphy because of urogenital prolapse, which was combined with an apex fixation in 5 cases. Doubt in patency of the ureter arose due to oliguria anuria in 4 cases and flank pain in 2 cases. In the 2 obstetrical patients, tears of uterotomy during caesarean section caused uncertainty of ureteral integrity, and the oncologic patient developed flank pain after surgical debulking due to ovarian cancer, thus suspecting ureteral damage. The next slide is titled Assessment of Ureteral Impairment. The assumption of ureteral impairment proved to be right in all the 6 patients with anterior colporrhaphy. In detail, 2 unilateral obstructions and 3 bilateral obstructions were detected. 1 patient presented with temporary ureteral kinking. No ureteral injury was verified in the patients with caesarean section and debulking procedure. This slide shows the frequency of the clinical symptoms oliguria anuria and flank pain in the 9 patients, broken down according to the presence and absence of ureteral obstruction. For the symptom oliguria anuria, the difference in the frequency distribution is statistically significant. As you see, this symptom can reliably discriminate between obstruction, yes or no, while flank pain does not. The following slide is about the onset of the clinical symptoms and the postoperative diagnostic procedures. Worrying decrease of urinary production occurred significantly earlier than flank pain. The time of primary diagnostics in the 5 patients with ureteral obstructions showed a large variation, of the mean being 25 hours. In the 4 patients without obstruction, no diagnostics was done in 2 cases. In 1 patient after a caesarean section and in the patient with ureteral kinking, renal sonography was carried out 53 and 44 hours after surgery, respectively. The next slide explains the significance of 3 common diagnostic tools in the detection of ureteral obstruction. Renal sonography, the most used method, focuses on the ectasia of the renal pelvis and normally provides adequate results concerning ureteral patency. The 1 case of pilectasia without obstruction is from the patient with ureteral kinking. Due to the small number of patients, the frequency distribution does not get statistical significance. In contrast, CT-assisted pyelography and cystoscopy are more invasive but superior to sonography. However, due to bulging of the vesicle bottom, cystoscopy after anterior colporrhaphy may be a challenging procedure because of hampering the identification of the ureteral ostia in the trigonum. Here you see the postoperative changes of serum creatinine arranged according to uni and bilateral ureteral obstruction to the left of the blue line, as well as ureteral kinking and absence of any ureteral injury to the right of the line. Unfortunately, 2 cases were lacking complete datasets. In the group with verified ureteral obstruction, the minimal increase amounted to 0.6 mg per deciliter, thus being 3 times as high as the threshold of 0.2 mg per deciliter reported from the literature. The patient with ureteral kinking showed a slight increase of 0.1 mg, remaining below the threshold. In the other 2 cases without ureteral injury, a slight decrease was observed. This slide represents the interventions intended to relieve the reverse ureteral obstructions. In 3 cases, finally, a uni or bilateral nephrostomy was done by the interventional radiologist following a longer time-consuming diagnostic procedure. In the 2 other cases, 1 day after the primary operation, a surgical revision of the anterior colporrhaphy was performed in combination with protection of the ureters by double J catheters following short invasive diagnostics. However, a 3 times longer average period after primary surgery passed before intervention by the radiologist compared with the intervention by surgical revision. The ureteral kinking remitted spontaneously after 48 hours. The next slide demonstrates the complete course of creatinine levels in patients with ureteral obstruction. The initial averaged increase of 90 micromole per liter as a result of the primary surgery is followed by a significant but not yet completed average decrease of 55 micromole per liter in the first measurement 2 to 20 hours after the interventions. Summarizing, we suspected ureteral impairment in a small collective of 9 patients after surgery, and we were right in 67%. All these patients underwent an anterior colporrhaphy due to urogenital prolapse. Luckily, only ureteral kinking was present in 1 case, remitting spontaneously. However, in all the other 5 cases, a real ureteral obstruction, unilateral and bilateral, had taken place, what raises the question, why is the ureter exposed to such a great risk in anterior colporrhaphy? The answer is to be seen in the right figure, taken from the surgical textbook by Reifenstuhl. The development of a urogenital prolapse involves a gradual displacement of the ureter. The normally light-rising run of the distal ureter will be affected by the descending organs, thus ultimately resulting in a downwards position of the ureter, which interferes with the surgical plane used in anterior colporrhaphy. Conclusions. Our preliminary data of a small collective show that patients with postoperative ureteral obstruction develop a marked increase of serum creatinine after a short time. The rise of creatinine is present even in unilateral ureteral obstruction. However, the clinical symptom oliguria anuria includes a high predictive value of uni or bilateral ureteral obstruction after surgery and arises even faster than the increase of creatinine. Therefore, prompt registration of postoperative urinary production is a valuable method to early detect ureteral impairment. In case of doubt, intravenous administration of 20 mg furosemide may raise the ureteral pressure, thus overcoming kinking of the ureter. If urinary production remains low, rapid onset of more diagnostics should be considered to check and remove the barrier as soon as possible. The benefit of postoperative assessment of serum creatinine seems to be useful for exclusion rather than for early detection of postoperative ureteral obstruction. Thank you for listening.